Good morning, everyone. I'm Bob Ravenscroft, Vice President for Advancement, here for our August 11th press briefing. A couple of quick things off the bat. Daily stats, they're arriving as we speak. There's a computer upgrade going on here at Bryan, so they're a little delayed. I expect them in the next couple of minutes, so I'll probably let Dr. Nora come up and speak and then report our daily testing results. A couple of real quick things. Myocarditis has been in the news a lot the past day or so. I'm just encouraging folks to go back to our YouTube channel or Facebook page. On July 23rd, Dr. John Stoiter, if you recall, presented on this and the impact it has on the heart, specifically related to young athletes, was kind of what he was presenting on the 23rd. So if you're looking for some things to research on that will be a good resource for you. And then with us today is Dr. Jim Nora, who has been here several times, as you know, and he's going to talk about guidelines for local employers to consider on returning to work in lieu of negative tests, and the impact that has on our testing supplies in the community. I think one other quick point that has relevancy, I just saw before I came up here, the American Rivers Conference, which Nebraska Wesleyan plays in, has suspended their fall activities. And one of the issues is the availability of testing with rapid turnaround that just made it unfeasible for them and other members of their conference, which is certainly in contrast to everything we heard about the Big Ten advocating for play when they had robust availability of testing and so forth. And I think that leads nicely into what Dr. Nora is going to talk about and some statistics I want to share with you real cephied We've talked about our 3 different tests on hand that we utilize, and the top of the pyramid is the cephied test. And right now at Bryan, we have 8 days of supplies on hand for that. Of course, we get additional allocations coming in. For our Luminex Aries test, we have 15 days of supplies on hand. So you can see how that interplays with decisions that impact some of the smaller colleges, may impact some others that are relying on testing for information. So Dr. Nora will provide some insight. Real quickly, another group of stats that I have before the testing results. What I can confirm is the number of COVID patients in the hospital remains at 8. 3 are from Lancaster County and 5 are out of Lancaster County, and there is 1 patient remaining on a ventilator and 2 patients in our intensive care unit. So I do expect the email on the daily testing stats to come in while Dr. Nora speaks, hopefully. If not, we'll send them out in a press release to the media afterwards. So with that, I'm going to turn it over to Dr. Nora.
Hello, thank you for having me back. I wanted to take this opportunity to talk a little bit about the dilemma that comes up about when people can return to work when they've had a diagnosis of COVID-19. And this is a question we're seeing much more often these days. We get calls in hospital outpatient setting and clinic outpatient setting. Somebody works at a particular company, and now that particular employer wants some testing done before that employee can return to work. And sometimes we're seeing the employer requesting a single negative test. Sometimes they want to get a couple of negative tests. And that's certainly very well-intentioned, and we certainly appreciate employers thinking very hard and carefully about when an employee should return to work. The last thing we want to see is having somebody who's infectious return to the workplace and potentially spread COVID to others in the work setting. So that strategy of using tests has really fallen by the wayside. And one of the challenges with COVID-19 and this entire pandemic has been that the guidance is updated frequently, often. It just doesn't stay the same very long. And the latest guidance from the CDC, I think, will be a little bit more enduring now that we have more information about the natural history of this illness. And that guidance was released in late July. And the bottom line is a testing to return to work strategy is not recommended. So the preferred way to get somebody back to work is not to send them in for a test. So how do you end up going about doing that, and what are the problems with the test-based strategy that was previously recommended? So there are really two problems. One is that it ends up using up some of our testing supply in a low yield activity. And while we've been really fortunate at Bryan, I think in most facilities in Nebraska to have adequate testing, it's always been a little bit touch and go, and we still on a weekly basis are discussing in pandemic planning how many tests do we have of this particular type of test. We have lots of really great in-house tests that give us an answer very quickly. The supply of those is extremely limited. And it's not that the supply chain hasn't increased. We are ultimately getting more supplies, but the demand nationwide for these tests has picked up because of further progression of the outbreak. And as such, we're still limited. The manufacturers allot us only so much testing. So we really have to spend our testing resources wisely. So we want to use those testing resources for high yield activities. So if somebody comes in and we're looking for a new diagnosis, that's really where we want to be using most of our testing resources, especially if somebody's getting admitted to the hospital. We want to know right away, do you have COVID? Do you not have COVID? Because that affects what part of the hospital you go to. Do you get put in the strictest isolation or just more of a standard droplet isolation? So that's one reason we would really like to not be using some of these lab resources for things that are a lower yield activity. The second reason to avoid the testing-based strategy, and probably even the more important reason, is that it just doesn't give good information. The problem, as we've discussed, I think at this conference before, is that the RT-PCR test detects dead virus and live virus. So what happens when somebody acquires COVID? You have all this replicating viruses in your sinuses, back in the back of your throat, and it's kind of like a bomb goes off back there. All these viruses, millions of copies, kind of blow up, and little remnants of virus end up all over the sinus cavities. So for some individuals, they clear all this debris out rather quickly, but in other individuals, it may take months to clean up this mess. And the RT-PCR tests will detect even the tiniest bit of RNA from this virus, even sometimes a couple months out, 100 days out. There are people who are positive who are having no symptoms. And having a positive PCR test that far out really means nothing clinically. It doesn't mean that the patient poses an infection risk to others. So the real test for deciding that is a culture. And that's much harder to do, much more complicated to do. But now that we're 6 months into this, it's been done. And people have looked aggressively for what's called replication competent virus. And the way they do that is they do culture. So you have somebody who has been asymptomatic maybe for a month, and they're still testing positive on the PCR test, and then you attempt to culture it, and the culture is negative. So what that really indicates is that this person is not shedding virus. They just have debris, this viral debris in their sinuses. So it turns out that for patients with mild to moderate symptoms only, we really can't find any evidence that patients have replication competent virus after 10 days. And in fact, it may even just be 6 days for most patients. So once you get 10 days out from symptom onset, or if somebody is asymptomatic, 10 days out from the date of their first test, there's essentially no risk of passing on this virus to others. Now, there are exceptions for people who are severely immunocompromised and who are hospitalized. You could, the CDC has recommended you go out to 20 days for those individuals. But for the vast majority of patients with symptomatic COVID, 10 days is the cutoff, and that's the recommendation. So the CDC says if you get out to 10 days and you've had no fever in the last 24 hours without having to use fever-reducing agents, and if your symptoms are better, they don't have to be gone, but the symptoms are better, then you are good to go and you don't need to worry about posing a risk to others in terms of infection. Now, having said that, the advice is that people who go into the workplace should be wearing a mask. So even if there is some slight degree of shedding, which the CDC says there is not, having universal masks in an indoor area is a terrific way to mitigate risk. So the bottom line is the recommendation from the CDC right now is to no longer use the testing-based strategy to get employees back to work. The preferred strategy is a symptom-based and time-based strategy. So wait 10 days after the onset of symptoms, or 10 days after the first positive test if a patient has no symptoms. And then at that point, employees would no longer be considered infectious. Of course, we still recommend universal masking.
Real quickly, the stats did come in. We have now tested 18,490 individuals, and our positives have reached 2,152. I believe I mentioned we had 2 patients on ventilators. That is accurate, but there's actually 4. 2 of them are just still on a ventilator, but they're no longer positive.
The most common cause of respiratory infections is just ordinary viruses. Rhinovirus is the #1 cause of the common cold, followed by coronavirus. And when I say coronavirus, I mean the wild-type coronavirus that occurred prior to SARS-CoV-2. So there are lots and lots of viruses that are out there, and we don't really have great testing for those. In the hospital, or if somebody's sick enough, and some clinics will test for a number of respiratory viruses. And so we occasionally see some of these. Right now, I'm not aware of a particular outbreak of anything like adenovirus or metapneumovirus. We always see these sporadically 12 months out of the year. So to answer the question, most of these patients who are testing negative likely have another viral infection. And most of the time when people have the common cold, we never identify the cause for that. In an academic setting, that can be worked up more rigorously, but even in an academic setting, most of the time we don't get a specific diagnosis. So that has not changed with SARS-CoV-2. We do not now have the ability to identify the cause of most episodes of the common cold, but the common cold can occur year-round, and universal masking is a way of minimizing risk of spreading that to others as well, so there's that as a side benefit. People who are having symptoms, the right thing to do is to get tested to make sure you don't have SARS-CoV-2. A single negative SARS-CoV-2 test doesn't necessarily completely rule that out. Always keep that in mind, that if somebody has very consistent symptoms with COVID-19, that doing a second test may be appropriate.